Well, good morning and welcome to the Roofers Convention. You are in the Roofers Convention, you know, here, you know, or Staples, either one. My name is Rick Bukata. I'd like to welcome you to our course. How many of you have taken a version of this thing in the past? Oh, a good number of recidivisms here. But there's also a group of you who haven't, so let me give you the ground rules. There's primary care physicians in the room and emergency physicians. And there's some other physicians. Can I see how many primary care physicians are here? Family practice, internal medicine kind of thing. PAs and NPs. Yeah, and there's some Canadians here. A bunch of Canadians. Look at right here. Look at the whole row. The Canadian doctor, you need to go back to that row over there with the Canadians. We're trying to isolate them. So welcome for the Canadians. Would you get out of the plane door? Did you notice anything? It's like it's 85 degrees here kind of thing, you know? I noticed where a lot of you have come from. You come from cold spots. A lot of cold spots represented here. Well, you're going to have a nice 4 or 5 days in Las Vegas. Those of you who have attended the courses before here, we've never been to the Mandalay Bay before. We worked our way up. We started with the Tropicana. And then we went to Harrah's. But we're getting up there now. We have the opportunity for you to attend any of these lectures that you want. So the primary care people can stay and listen to emergency medicine the whole time. Or if you want, the emergency medicine people can go over to listen to primary care when we split up. We're all together for the first 2 hours till 9:30. Our faculty, we have a really nice faculty for you. In the emergency medicine side, we've got Dr. Greg Henry, the junkyard dog of emergency medicine. Former president of the American College of Emergency Physicians, who's been doing this with us for at least 20 years now. So Greg, thank you for coming. Greg is basically under a lot of stress right now because he just realized that... Okay, I won't say that. Okay, I won't say that. Greg's here. We got Billy Mallon. Those of you know Dr. Mallon. He is basically... he's being sedated as we speak right now, for those of you who know him. We have Al Sacchetti. Al Sacchetti's from New Jersey. He's from Our Lady of Lourdes Hospital in New Jersey, where he was recently chief of staff. That's very cool. I should say Dr. Mallon is on faculty at University of Southern California, the biggest residency in emergency medicine in the country. Any graduates from that place here? Just me? Okay. Anyway, they used to do 72 house staff in emergency medicine, biggest program in the country. They've been cranking out ER doctors like a factory since the early 70s. And I got out of there in 1970, I don't know, 1975, the Mesozoic period of emergency medicine. We also have Diane Birnbaumer. A lot of you know Diane. And who else we got? I guess that's it. On the primary care side, we have Mike Wilkes. Mike is dean at UC Davis, one of the largest primary care training programs in the country. He is an internist, and we also have Nate Link. Nate's from New York, is in charge of internal medicine at anybody, Beth Israel? One of those big hospitals there in New York, big hospital. Anyway, those two are there. For our sessions, we're going to be here together for the first 2 hours. At the end of the first 2 hours, the primary care doctors go out the doorway there, and right on the other side of this wall is the room for the primary care sessions that are going to be taking place there. Some people have asked, you know, well, do you have a manual for both? We don't have a manual for both, but what we will do is we will get you a CD that has the manuals for both. So should you choose to, you can have it and print it out when you get home kind of thing. We'll do that. Any questions? We are going to video this, so if you're here with anybody other than your spouse or something like that, you know, you should probably separate yourself, at least for the time being, during the videos, that kind of thing, okay? I would appreciate your participation, so please involve yourself in this thing. We are changing the format a little bit. For those of you who have participated we started this in 1985. For those of you who have been around a while, we usually give an hour talks. We thought we would try to focus and narrow it down and see if we can do more talks, but on narrower topics. So we have like 32 topics, ridiculously large number. The idea here is to focus on questions in these areas. What's the evidence? Because we're talking about literature-based course. So in your manual, those of you not taken this thing before, you see all of these abstracts from the literature. We have two services, emergency medical abstracts, which started in 1977. So we got about 10 or 12,000 abstracts. So every year we put the course together, we pull our abstracts. What do the abstracts say on this? We're looking at evidence-based medicine, the best way, the most cost-effective way, the most pro-patient way to do things. And then we have a similar thing on primary care medical abstracts, tricky name, where we do the same thing. We survey 600 journals a month, pull our papers. There is a common database that overlaps a little bit, but the cholesterol papers and things like that, and high blood pressure, those clearly are primary care. Those will be discussed over there. So I would encourage you to please, we're all friends, we all are in the same occupation, we all have the same issues. So please feel free to interject and give me your opinions or your disagreements. I hope that we will, if you leave here without changing any of your mind about what we do, then you've come to a nice warm place and you've had an opportunity to gamble. But we would like to push you to look at your practice and say, what's the evidence supporting what we do, those kinds of things, so that, in fact, we can leave here saying, I've reaffirmed what we're doing is reasonable based on the literature. Actually, there's some stuff that suggests we can do it a different way. So all of the data is in your books. Hopefully, you will not need to feel the necessity to take any notes. And we will begin with our first session on pediatric rehydration and feeding. Pediatric rehydration and feeding. Now, any primary care doctor, and I know all the emergency doctors, are going to have a lot to do with, everybody wants to know, well, what can they eat? Because kids have a very stereotyped approach to illness. They have fever, vomit, and diarrhea. That's it. That's it. You know, not very imaginative. You know, it's always the same. So you pick up the chart, fever. Pick up the chart, fever, vomiting, diarrhea, fever, vomit. You know, if you know those three, I shouldn't say this. Any pediatricians in the audience? I've already screwed that up. There, okay, thank you very much, doctor. So listen, any other specialties represented so I know who we're talking to here? I'm going to be a little bit careful. Who am I insulting? Yes, exactly. Come on now. I should have not prefaced it that way. I should have been more open about it. You're nobody else other than radiologists. Come on. I know you're here. Pathologists, come on. No other specialty here. We're all primary care doctors. Yeah, right. All right. So they always want to know, what can I feed them? What can I eat? And there's so much tradition and baggage related to this that it's just kind of amazing. I'd like to start off by basically putting the importance on why it matters so much to these kids. Why do we focus on dehydration? We don't really particularly focus on adults like this, but the kids, we focus on dehydration. Well, if you look at the book there, it says, if you're a kid and you weigh less than 10 kilograms, in terms of your maintenance fluid, it's 100 mLs per kilogram for the first 10. So 10-kilogram kid is 22 pounds. A 22-pound kid is 1 year old. That's about a 1 year older. That kid, maintenance fluid, 100 times 10 is a liter a day. You put this little kid beside a liter, that's a lot of fluid for a little tyke. And for the second 10 kilograms from 11 to 20, it's 50 mLs per kilo, and from 21 to up, it's 20. So these little kids disproportionately take lots of fluids that are required to maintain them. If you were to take a 220-pound male, a 100-kilogram male, and apply the same numbers, you'd have to drink 10 liters of fluid a day to match what a little kid of 22 kilograms would be expected to take. So they're disproportionately taking in a lot more fluids than we do, and they need to. And so it's easy for them to get into some compromise when they're not getting enough. So I think that that kind of paints the picture about they need a lot more than we think, and certainly more than an adult would need. The question is this kid dehydrated? We have history from the parents, we have physical examination, and we have some lab tests to look at that. What is the gold standard? The gold standard is something that really is not useful to us. The gold standard is, what does this kid weigh when they're normal? Well, we don't know what they weigh. They're sick now. And so they always talk in all of these studies about, well, we weigh them when they're normal. This is what they weigh now. Isn't that right, doctor? How can you possibly deal with something like Well, what did the kid weigh when he was normal? The mother doesn't know. Nobody knows. So that this tends to be a problem when you look at these studies. The other thing is there's a kind of cute little paper here about you need to take the diaper off to weigh these kids. I mean, the real anal people, well, you take the diaper off because obviously the diaper is going to weigh a lot. There's a good study in here that says you don't need to take the diaper off. It's from the Hospital for Sick Children in Toronto. You get the Canadians there. You know that one, a pretty famous hospital. What's the name of the hospital across the street?
Well Children.
The Hospital for Well Children. It's a much smaller hospital, much smaller. They don't have very many patients. What kind of name is this? This name has always bothered me, the Hospital for Sick Children. You know, I mean, it's kind of so obvious, you know. It's kind of subtle. I know it's a little early in the morning. A lot of you have traveled. A lot of you have done a lot of traveling, you know, maybe a little jet lagged. Okay. So what did they do? There's 217 kids. They weighed these kids with the diaper on, weighed them with the diaper off. So they said, if there's a 3% difference in the weight, we will consider that significant. 4 kids out of 217 had a more than a 3% difference. And who were they? There were 3 of the 4 were neonates. So neonates, definition, less than 28 days, you know, first 28 days of life. So this basically says you can leave the diaper on for all kinds of reasons, like it's time-consuming to take the diaper off, or risk of contamination, infection, positive environmental effects. What the heck is that about? Positive environment. So leave that diaper on. Of course, we don't really care that much, you know, whether it's an ounce or 2 here, different, and maybe the person that you would take it off and here's a little neonate, you know, kind of thing. What's the literature say about physical examination and lab tests? That's addressed in the second paper there. I think this is one of these JAMA studies that looks at the world's literature. One of the things it says is parental reporting of symptoms was not useful. You know, it's kind of good to know, actually, because how many times have you had, Johnny has not peed for 3 weeks. You know, and that's what they say. Johnny hasn't peed for 3 weeks. Kid looks fine, you know, it doesn't look, you know, eyes are wet, mouth is dry, wet. But so mom and dad, you could disregard what they're saying. Well, I don't know that I would necessarily do that, but they suggest that, and there's another paper coming that says, if you ask them in the right way, and then you get much more useful information. And so they say, well, here's a computer program, and they can put the screen and do that. Well, obviously, we're not going to do that, but this basically discredits, to a certain degree, the parents in terms of helping you quantitate whether this kid's dehydrated or not. They say also, this paper, number 2, says abnormal capillary refill, abnormal skin turgor, and abnormal respiratory patterns tended to be noted in the setting of mild dehydration. Mild dehydration, abnormal skin turgor, abnormal breathing, capillary refill. That doesn't sound like a mild dehydration to me. The fact of the matter is that we have other papers that said capillary refill is actually really quite poor in terms of assessing perfusion in kids. This paper, I don't like that. They also talk about classic findings. Here's a list of classic findings, and they say these classic findings have a low likelihood ratio for dehydration and wide confidence intervals. But look at the list. Everything that we would classically think is this is in bad shape. Sunken eyes, dry mucous membranes, cold extremities, weak pulse, abscess tears, increased heart rate, sunken fontanelles, and poor overall appearance. We would think all of those things would be consistent with a nasty degree of dehydration. When they look at it in terms of the literature, they said, you can't really depend on these kinds of things, although it would make sense. The more of these things that you had, the more likely the kid's going to be dehydrated. What about inter-observer agreement? Dr. Henry, what do you think? Is this kid dry? Dr. Bukata, what do you think? Is this kid dry? They note that there is substantial inter-observer disagreement regarding the level of dehydration of little kiddies. What about a little lab work here? BUNs and bicarbonates. If you send that stuff off, well, in adults, we look, if we see a BUN of 35 and the creatinine is normal, we say, oh, geez, this guy's pretty dry kind of thing. They point out that bicarbonates and BUNs are not very reliable in kids at all. The fact is that they have to be grossly abnormal for them to be reflecting degrees of dehydration. They basically conclude these are not good tests to assess dehydration in kids. However, if the bicarbonate is normal, you were to do it. What's the matter here? I'm what? I'm scratching. They say if the bicarbonate is normal, it's not very likely that the kid's very dehydrated at all. All right. Well, So like a lot of other things, like pulmonary embolism, the more things that you have consistent with the diagnosis, the more likely the diagnosis is going to be correct. But if you put your hat on any one of those things, you are basically on fairly thin academic ice. There's some spots right in the front of the church. I got one right here for you, right? These are really the good spots. What's the World Health Organization to say? The World Health Organization, this is about all of these third world countries where they are experts in dealing with dehydration, like Bangladesh and India and those kind of places where they write their papers about dehydration. They say, listen, don't bother with this 5%, 10%. And the fact of the matter is, those of you in the room, you knew that 5%, 10%, 15% was just kind of like, where'd you get that number? You kind of made something up kind of thing. They say, the World Health Organization says, none severe, and some. That's it. That's all we have to do. That's good enough for government work. Because these other numbers are giving you a false sense of this is a high science. It really isn't. What about lab tests? Lab test ordering in kids is extraordinarily variable. I don't know if you've seen in your own practice what your colleagues do when they're assessing these kids. However, at our hospital, we have people who never met a lab test they didn't like. We've got heavy orderers, and we got light orderers. On the kids side, I'm definitely a light orderer, but we have a doctor at our hospital. He's full-time faculty at the University of Southern California, teaching doctors to be emergency medicine doctors. He's faculty, full-time, moonlights at our hospital. This guy orders laboratory on everybody, particularly on kids. What does he find? Not very much. I want to show you a paper that's really pretty good on lab. This is a paper from this is, I think, number 3. Is this number 3 or number 4? Anyway, it's about an academic place. Pediatric emergency medicine faculty and fellows in pediatric university-affiliated ped place. Now, how well you can extrapolate that to community practice or not. And the question is their practice state-of-the-art just because it's a university? Are they the exemplars by which we should emulate? I'm not so sure that that is necessarily the case. The fact of the matter is that they're teaching residents, and in that environment, there tends to be a heavy utilization of laboratory tests. Well, in this study, what they did is they had this computer physician order entry. All of it were being dragged into physician computer order entry. Just for sake of discussion, how many of you have physician computer order entry where you are? 1, 2? Oh, all the Canadians. All the Canadians. So, and a few over here. Are you guys Canadians? No, you're from South Carolina. That's right. Okay. Well, they said this is the wave of the future kind of thing. You don't make mistakes, supposedly. There's been a lot of interesting stuff about this. Well, in any case, they put the prices for lab tests in the computer. When you ordered the lab test, their prices came up. And the baseline, these guys were ordering 60% of their kids were getting lab tests, which is a really high number, I think. When they put the prices on, the number dropped down to 34% of the doctors would get lab tests. And that has been duplicated at Brigham and Women's Hospital in Boston, all residency-run place. They put the prices on. You see a dramatic decline in the use of lab tests. They found that when the lab tests basically went in half, they found there was no evidence that this was proved to be harmful to the children whatsoever. The fourth paper looks at the routine measurement of electrolytes in kids. This paper concludes that lab work should be ordered routinely in kids who have dehydration worthy enough to get an IV. So that's their cutoff. If you're sick enough, you should do electrolytes on those. I'm going to try to make the case that they just proved just the opposite. They had 182 kids. All of them were getting IV fluid for their dehydration. Despite the fact that 60% of these kids were considered to be mildly dehydrated, and lo and behold, almost half of them had at least one abnormal test, which really can say, well, there you go. Look at all the abnormal tests we found. Now, it wasn't just electrolytes, measured BUN and glucose as well. Electrolytes, BUN, and glucose. So look at half these kids. That's why you ought to do this. The fact of the matter is that when they looked at the kids who had abnormal tests, only 10% of them had what they consider to be significant abnormal tests. And what were those two significant abnormal tests? There were bicarbonate and glucoses, bicarbonates and glucoses. Well, the idea that you would have a bicarbonate as an abnormal low bicarbonate in the setting of dehydration is consistent with dehydration. It is supposed to be there. The fact of the matter is that these kids may have some Starvation, they may be breaking down their fats. They may be ketotic now because they're not utilizing sugar. They're breaking down fats. They become ketotic. That makes them acidotic, and so they may have some starvation ketosis going on, generating a metabolic acidosis, so their bicarbonate is low. You fix that, you fix the bicarbonate problem. The more occult issue was that a substantial subset of these kids who had abnormal tests had low blood sugars. So the clinicians, they ordered electrolytes on everybody. The clinicians would have not ordered electrolytes in 8 of the 18 kids who had what they considered significant abnormalities. They therefore conclude there's nothing by the physical exam of these kids that would suggest which ones need electrolytes, therefore do them on everybody. And you'll pick up the low sugars and you'll pick up the low bicarbs. The low bicarbs you're not going to do anything about except fix the kids. You're not going to give them exogenous bicarb. And yet, yes, we would like to pick up a low sugar. So they say, because you can't predict them on their physical exam, do it on everybody. But the fact of the matter is that the only thing that you're going to change is the bicarb. So I would suggest that we have a lower threshold for, this kid's got a lot of vomiting, diarrhea. Let's get a blood sugar on this kid. It's a little finger stick kind of thing. We don't need the bicarb. We don't need all that other stuff. And number 5, it goes along with that. This is another paper that points out hypoglycemia in the setting of gastroenteritis. In this study of 196 kids, 18 of them had glucoses less than 60. 18, that's about 9%. That's not an insignificant number, had low blood sugars. The vast majority of those people had low blood sugars. They were between 50 and 60. So it wasn't like, horrendo. One kid had a 34. They also said that there were no predictors. And so this would suggest, if 9% in this one study, so a similar percentage in the other study, had low blood sugars, maybe we should have a lower threshold for doing blood sugars in kids who have gastroenteritis because there's no predictors. And if a kid's got a 35 or 40 blood sugar, I think we'd know that. We should know that. These kids basically are not eating. Is the problem. And so we could fix that if we know about it. What's the advantages of I Rehydration over oral? Well, there are 3 studies here. All of these studies say the same thing. They basically say, the American Academy of Pediatrics, the World Health Organization, the CDCP says, even in moderate dehydration and mild dehydration, the initial treatment should be oral rehydration. And yet, in the United States, we are disproportionately happily starting IVs in kids. This literature talks about outcomes, length of stays, parental satisfaction with care. The fact is that it's often difficult to start IVs in kids. In the first study here, a quarter of the kids required 3 or more attempts to start their IV. So all of these things were going on. The fact of the matter is that they have these nice protocols for oral rehydration. Oral rehydration is about small amounts frequently in the vomiting kid, and in the diarrhea kid, that doesn't even become an issue that, in fact, this kid's going to vomit this stuff. Small amounts frequently, whether by drinking or there's one paper here where they talked about, we put an NG tube down, put a little MG tube down a kid and just dripped this stuff in, went through, everything was fine. Rather than starting an IV, they have a protocol in there that you might want to take a look at. But we are IV happy. One of the things that should be pointed out is a lot of these papers are from third world countries where it's kind of a big deal to start on an IV, and it's certainly lesser so. But when you looked at parental satisfaction, there's a paper here that basically said the parents were twice as satisfied with the care when they could avoid having little Johnny needled over and over and over again to give them their IV fluids. Number 8, a meta-analysis of 16 randomized trials. High success rate of oral therapy. What was the flunk rate? 4%. 1 in 25 kids who's tried on oral rehydration therapy flunked it. 1 in 25. Frequent amounts, small amounts frequently. Let it go through, let it go through, let it go through. Every 15, 20 minutes, there's a couple ounces, over and over again. The parents learn to do that. The parents are the ones who are giving the kids the Rehydrate, those kinds of things, and they say, geez, this seems to work kind of thing. So this analysis of 16 papers said flunk rate 1 in 25 kids. High satisfaction scores twice as common when the kids are given oral or NG tube feedings. And they talked about the studies were done in third world countries. Major adverse events were more than twice as common in the kids following IV rehydration. Yet, when you look at our performance in this country, we're basically heavy into start the IV. Which is better, gradual refeeding or immediate refeeding? So this falls into diarrhea or vomiting. Diarrhea is pretty straightforward. Diarrhea, and the same applies to vomiting. People's beliefs on this is very inconsistent, very inconsistent. You ask some people how to do it, they give you a totally opposite what the other people say. That's why people talk about the brat diet. Brat diet. You talk about high science, bananas, rice, apples, and toast. Bananas, rice. What is that about? Has that been studied extensively? No, somebody just made that up. Here, give the brat diet. You know, they named it after a kid. The fact of the matter is there's very little information to support choosing certain foods over others at all. So the idea here is, how soon do you refeed these kids, and what do you refeed them with? Paper 9 is an assessment of the world's literature on this topic. The world's literature on this topic is 12 papers. You would think we're seeing tens of thousands of, hundreds of thousands of kids, and everybody wants to know, what should we feed Johnny? When should we feed Johnny? How much should we feed Johnny now that he's got this gastroenteritis? And there's 12 papers that talk about this. There's no data to support the superiority of gradual refeeding over immediate refeeding. And when they talk about immediate refeeding, basically they talk about rehydrating and then refeeding. How long does it take to rehydrate? 4 to 6 hours. 4 to 6 hours. Some people drag it out over 12 hours, 24 hours, that kind of thing. 4 to 6 hours. Fill the tank back up and give them pizza. The idea is rehydrate quickly, 4 to 6 hours, full diet thereafter. And if the kid's on a formula, the issue will be, is it full-strength formula? The answer is yes. It's full-strength formula. These kids are calorie depleted. The fact of the matter is it's been shown in gastroenteritis, they need more calories than they would at baseline. So full-strength formula, the question is, we'll talk about whether it's soy formula or not. So the whole thrust of these papers is rehydrate them quickly, 4 to 6 hours, feed them full. This idea of, and I've heard doctors do this, this is 1920 stuff. This is the idea of therapeutic starvation. What we're going to do is we're going to rest the GI tract. Have you heard of this one? Rest the GI tract. So we're not going to give Johnny anything for the next 4 to 6 hours. Have you heard doctors do this? I have heard doctors do this. And we tend to be marked with what we've learned in our training programs. We take that baggage with us forever. So when I was trained in the 70s about GI rest, we do GI rest kind of thing. The fact of the matter is that these kids are starving. They are not eating adequately. They've got diarrhea. There's some issues about their calorie intake. That's why their bicarbs are low, because they are catabolizing their fat because they're not eating. So the fact of the matter is this idea of therapeutic starvation, which came from the 20s, is history. The idea is to refeed these kids. No problems with refeeding them, and in the vast majority of the case, they can take regular old formula if they're on formula. Now, number 11 deals with the acute diarrhea. World Health Organization paper currently recommends full feeding during the entire course of the illness. Full feeding, World Health Organization. American Academy of Pediatrics is kind of like, it's not really come out clearly about that. They really ought to. We're going to skip 11. I don't like that one. 12 is an old paper, and that might discredit the entire paper because it's old. It's 1992. They asked a bunch of pediatricians and family doctors about, what do you do for kids who've got gastroenteritis? So how many of them supported rapid rehydration, 4 to 6 hours, fill them up, done? 2% of the doctors said, oh, that's reasonable, 4 to 6 hours, that's good. 2% of the doctors said in 1992. The fact of the matter is that 60% favored rehydrating them over 12 to 24 hours, slow refilling the tank, when in fact there's no reason necessarily to do that. 40% initiated formula or milk immediately. That's good, that's what you're supposed to do. 40% would employ a lactose-containing formula. We'll talk about that briefly in a second. 70% favored initial use of dilute milk or formula. There's no reason to use dilute milk or formula in these kids. A third of them indicated that children previously on solid foods would be placed on a gradual diet, bringing them back up to the solid foods. They would be on their brat diet. 30% said, let's do that brat diet before we initiate them on their normal foods. Contrary to the American Academy of Pediatric recommendations, 44% would delay reintroduction of solid foods for 2 or more days. 13, another paper supporting rapid rehydration, a position supported by the American Academy of Pediatrics. So these papers are all basically making the same point here. Soy formula. Soy formula. There's 4 papers on soy formula. One says was not supportive, 3 were. The one that was not is number 14. This is an unusual paper. This paper from Mexico. They took 87 kids between the ages of 5 and 36 months who had gastroenteritis. They probably had gone to the United States, got sick on tourista in the United States and went back to Mexico. And they made this gruel up. And you see in the book what the stuff's made of. It looked like vegetables and carrots and this and that. And they made this up, and they compared this with kids who got soy formula. And actually, the kids did better when they gave them the gruel that they made up in Mexico than on the soy formula. However, the other 3 papers are in favor of soy, like this paper number 15. That's a paper from Hospital Sick Children. 39 kids got soy formula isomil versus lactose-containing, and they found that the duration of diarrhea was 2 days shorter, 4.5 versus 6.5 days. And that's the whole issue here, is that some of these kids, when they've got this gastroenteritis, and there may be some issues about their villi and their lactase and a relative lack of this ability to deal with this milk sugar lactose. So if you can't break down lactose, then there's the opportunity to create an osmotic diarrhea where, in fact, because of this deficiency, as a result of this viral illness that has caused this diarrhea, you make it worse because now you're having trouble dealing with lactate. So this paper suggests that 2-day longer diarrhea in this small study, number 15. Number 16 is also a paper that talks about it will skip it, and 17 is a paper that I like. Somehow they were able to determine that 40% of kids who had gastroenteritis were lactose intolerant, 40%. So they said, there's really no way for you to predict these kids. A substantial subset of them are. It wouldn't hurt to put them on a soy-based formula for a short period of time after the gastroenteritis because of this relatively high percentage, and you don't know who they are. Some people don't agree with that, but I personally think it's not unreasonable. If these kids are sick enough to go to a doctor because they've got diarrhea, that the idea of giving them, say, okay, here are some, I would suggest that for the next week we switch over to this soy-based formula is not unreasonable, although other people would say the vast majority of kids don't need to have that done. But I don't think, since the number is relatively high, that it's unreasonable. And the last paper here, the last paper is about the ubiquitous apple juice. Apple juice. Apples got pectin, right? Kaopectin. Apples are kaopectin. Apples are kaopectate. Apples are kaopectate. That's good for diarrhea. No, that's not the case. This apple juice here is sugar and water. And you see these little runts running around with these bottles. We're drinking this apple juice constantly. It's sugar and water. And to the extent that they have some difficulty handling sugar in the setting of their diarrhea, this number 18, 5 patients with chronic diarrhea were ultimately attributed to excessive apple juice consumption in the setting of carbohydrate malabsorption. Now, it's not necessarily fair to say, well, every kid you're going to give apple juice to is going to be prone to this. I don't know if you've ever had this kind of apple juice that is unfiltered apple juice. You know, that they have it in Michigan at the time of the year when it's fall and they're squeezing all these apples and making apple cider. And that stuff is just fantastically good. And you have a couple, 2, 3, 4 glasses of that stuff. What the heck happens to you? Or is it just me? You get the world's... So the fact of the matter is apple juice can be your enemy in the setting of diarrhea. And I think that this paper is just kind of a little marker of that. So that's a half hour on pediatric dehydration and feeding. Any of you have any differences? Or doctor, come on, give us your opinion here.
This whole